Hi, everyone. Thank you so much for tuning in virtually today for this fireside chat with Dr. Allison Holt of Talkiatry. I'm going to let her introduce herself momentarily. But first, I'm Anastassia Gliadkovskaya, a staff writer at Fierce Healthcare covering health equity. I'm really looking forward to this important conversation on the intersection of migrant mental health and emerging care models. But Dr. Holt, Allison, I'll turn it over to you to introduce yourself.
Thank you. So my name's Allison Holt, and I'm a child and adolescent psychiatrist. I'm also the National Medical Director at Talkiatry, and we recently signed a contract with the Health and Human Service Department to treat unaccompanied migrant children. And so this is really exciting also for me to talk about this.
Thank you. So right now, the United States is facing a worsening youth mental health crisis. Mental health disorders, including depression, anxiety, and suicidal ideation, are increasing in young people. There have also been increases in pediatric mental health emergency visits throughout the pandemic. And at the same time, we are seeing an influx of migrants from all around the country, from South and Central America, Africa, and Asia. Many are children, and providers have been sounding the alarm about their urgent need for mental health support. Timely intervention is critical to preventing worse outcomes, yet there is already a severe national shortage of child and adolescent psychiatrists. So I'm excited to talk with you, Allison, about how Talkiatry is gearing up to treat these unaccompanied minors that are under the care of the HHS. So to start, maybe we can talk about what kinds of traumas are commonly experienced by migrants and how do these experiences impact their mental health?
Yeah, that's a great question, and it's one that's really important that psychiatrists understand before they start to see migrant youth or anybody who is a refugee, because they have the people who are coming have an experience that most of us in the United States have never had. So I think a lot of it just depends on where these people are coming from. So if they're coming from Central America, they might have had a really long trek up to the United States, and it could have been very dangerous. If they're coming from a company or a country in Africa, they might have been enlisted as child soldiers, and so they have a very different experience. They may have seen their loved ones killed in front of them. They've been pulled away from their family, from their friends, from their educational system. So there's just a lot of trauma that is kind of similar, but can be very different based on where these kids are coming from.
And can you talk about why it's important to address these early on when they first enter the country, and how, if left unaddressed, these conditions or even just symptoms might spiral down the line for them?
Yeah. So, what's interesting also is there's a lot of resilience. So in general, a lot of the people who come and are migrant and or refugees do experience maybe PTSD at the beginning, and then many years later they could have a full recovery or great partial recovery. So I think that it's important to think about what goes wrong, but also what goes right, and that a lot of them are able to overcome this. But when they first come, they are really dealing with a lot of trauma. And again, that could have been violence, and it could have just been being pulled away from their family and coming to a new country with a whole different culture. In the past, psychiatry, we've never really been in the prevention space, and psychiatry in the last 10 years, 15 years has really come into a prevention space. And so one way to prevent long-term post-traumatic stress disorder is to help people make sense of the trauma that they've experienced right at the beginning, and start to intervene quickly so that they can make sense of the trauma, so that they can not avoid it, avoiding it in their thoughts, that doesn't help, and talk about it, get support. And that's probably the best intervention that we have right now for prevention.
Yeah, that's really interesting. I mean, Yeah, it makes sense. And I know you haven't started treating this population quite yet. You're gearing up for the next phase. But when you are thinking about this population, these kids, what sort of social determinants of health do you think are at play that you might take into consideration during your treatment?
So that is a big focus of for us. And as psychiatrists, we've been taught to look at what we call biopsychosocial. So when you're thinking about the care of somebody, you think about what's biologically driving this, what is socially driving this, kind of the social determinants of health. And so we really do need to look at that, because if you can shore up some of those social determinants of health, like make sure that they have access to food, make sure that they have a support system that's helping them educationally, that is a way to really intervene. And so some of the social determinants of health that they really struggle with are poverty, frequent moves, and so not that stability, worrying about their legal status. That's another a thing that they have to deal with, that a lot of people in the United States don't have to deal with. Lack of access to healthcare, lack of translators. So even if they are in healthcare, a lot of, like, let's say you go to a small clinic, they don't have the capacity to hire a translator in every different language that they might see. So those are some of the barriers that they have, and some of the social determinants of health that they run up against.
Yeah, those are some of those are quite different from, like you said, what a lot of people in the US might typically experience. And how are you planning to leverage telehealth or digital tools to meet some of these needs, whether it's translation, maybe legal aid, connecting them to social services, and just in general, providing psychiatric services?
So when these kids come, they're unaccompanied by guardians, and so they go into a shelter. And so those shelter staff are comprised of social workers who are going to get them connected to different social services. But for us, the way we think that we can intervene the most is that we have a national organization with a lot of child psychiatrists. And since we're telehealth, virtual health, we don't have to be there in every state at every shelter helping out. We can, link into them in a virtual way, see those kiddos, and start to get them the help that they need.
Mm-hmm. Got it. And I know
and we can have translators as a part of that. Sorry to interrupt.
No, that's great.
That's something, that not all organizations can do.
Got it. So because of the digital infrastructure, it's able to be more flexible and adaptable to different settings.
Mm-hmm. What we found over, when COVID started and everything went to telehealth, or a lot of practice went to telehealth, was that we all of a sudden had access, or our patients had access to psychiatry, who were out in rural areas, who would have had to drive 3 hours just to see a child psychiatrist. So the same is true for these unaccompanied minors, that they don't have to travel hours to go and find a psychiatrist.
Mm-hmm. Yeah, I could see that being really useful. And in terms of maybe creating certain peer groups or specific programs or resources that are tailored to this population, what is Talkiatry thinking about as you head into this new population?
Do you mean peer groups for the children, or peer groups?
Yeah, or maybe for their families, or
so for the children, luckily they are in shelters with other children, and those services are trying, those social workers are trying to bolster the peer group and the support that they have. I think for us, we also just have a peer group amongst ourselves, because this is a different population than a lot of us were trained to treat in residency. I wasn't necessarily trained to treat this because it was many years ago. And so we are working together to develop our own peer group of psychiatrists who can talk about ways to intervene that are more effective, and we're doing a lot of education so that we can be educated on what different groups of refugees, what kind of needs that they might have, what kind of experience they may have before coming here.
Like maybe tailoring or learning more about culturally competent care and understanding what treatment might be more might be needed for specific
right. Needed and accepted. So different cultures have different ideas about what causes mental illness and what you can do to treat it. And they may have certain biases against mental health treatment. You don't talk about your feelings, you don't talk about your problems, you don't take medication, you know, so we have to understand each culture to understand how we need to navigate the different cultural beliefs and ethos that are important to them.
Yeah. And what about care coordination? How are you thinking about coordinating with perhaps the primary care doctor if they have one? Or you mentioned that when we spoke last, some children age out of being eligible for this program. So how are you thinking about continuity of care for them?
So this is a great question for a lot of reasons. So there are some kids who won't be placed outside of the shelter. The goal is to get them all placed outside of the shelter with either a family member that they know or don't know, but is willing to take care of them, or with some other family or organization so that they are able to get out of the shelter. Some kids will end up being 18 and haven't gotten placed. And so those are the kids that age out. So continuity of care is important for those that are aging out, but also for the kids that even are just being transferred to another state, to a family member. So luckily, as a national psychiatric organization, we do have doctors in almost all states. We're in 43 states. So hopefully we will be able to have an ongoing connection with that child, or at least have another psychiatrist who has a license in that state. Let's say I have a license in Minnesota and New York, but if a patient goes to California, hopefully I can transfer that patient to another psychiatrist that's in our organization who can see the whole workup and all of the things that we've been doing, so that they can just continue that care. So I think that that's really important. At any time, whether they age out or whether they just move.
Mm-hmm. So I guess, is it fair to say that that's enabled by being a telehealth provider and the fact that you can have this large network across nearly every state, where if someone does move or ends up transferring somewhere else, you can have that picked up either within your network, within the Talkiatry network, or transferred to another provider?
Yeah, usually we can transfer in our own network or in our own organization. Maybe I can't see them because they're in California and I don't have a California license yet, but one of my colleagues can, and they will have access to all of my information. We can do a warm handoff. I would talk to that psychiatrist and say, this is what's been going on. This is where I was thinking of going next in terms of treatment. So that's, I think, the best way to have continuity of care if I can't do it myself.
Mm-hmm. Yeah, that makes sense. And to what extent is it important for you to coordinate with, say, a primary care doc, someone who's not a mental health provider, to make sure that you're looking at a person holistically and treating alongside their other treatment plans, if they have any?
Yeah, that's a really important thing for us too. It's a great question because one of the things that we wanted to make sure is that all these children have had a physical exam by a primary care physician before they see us. And so they have all been worked up. That's what we call it. But all have been seen by a primary care physician or a pediatrician who has checked to make sure that they don't have, a heart disease that impacts what we might do for treatment. So if somebody has a certain type of heart disease that could interact, my medication could interact with that, I need to know that. So it was really important for us to make sure that we did have that, that they were first evaluated by a primary care physician. One of the things that we found with children who are migrating up here or over here is that they often haven't had great health care. So they are coming with things that haven't been diagnosed in their home country in a way that we don't normally see in the United States. So something like a heart disease usually is diagnosed when they're young if it's a congenital heart disease, something they were born with. But these children are sometimes coming and haven't been evaluated for that until they were 10 years old. So it's very different.
Yeah, thank you. That's an important point. And in terms of other resources or support that is available to these children within the HHS, can you talk about how you plan to leverage some of those tools that might be available either to you and your team of psychiatrists or to the children themselves?
So I think that so HHS really, their Office of Refugee Resettlement, they really have a robust program for intervening with the social support. So we can identify the social needs, like you had talked about earlier, the social determinants of health. We can identify, and then we will work with the shelter staff to make sure that they have the support that we think is necessary. And that might even just be therapy. I mean, it might not even be the social interventions of a social worker and getting on certain programs, but it might be therapy. And so we can intervene and say, this is the type of therapy that we think that they need. These are the these are the things that they're really struggling with. Maybe it's food intake. They've had food insecurity their whole life. And so please help us shore that up for them. So I think it's really a partnership with HHS and the Office of Refugee Resettlement that we are also collaborating with them to make sure that we give full care rather than just targeted mental health care, because we are more than just our brains. We're also, we need food, we need stability, we need shelter, we need education. These are all the things that the children need that the HHS is working on getting for them.
Yeah.
We can direct some of that, but we're not the ones that really get it for them.
Yeah. Okay. That's good to know. And you mentioned that you are currently in this kind of education phase, educating yourself, your team members educating themselves on the unique needs of migrant youth, and even more specifically, the unique needs of different refugees from different countries. And what sort of resources are you turning to as providers to help educate yourself? Because I would imagine this is not typically something that's recorded in an official study, or these resources might have to be kind of put together by yourselves or maybe through nonprofits. So can you talk about that process?
Yeah, so HHS has, we asked them for resources to help get us educated, so they were able to do that. And I should say a lot of our psychiatrists are already educated in quite a bit of this. We all go through cultural competence training in our residency programs, in our training, and it's required even, when you're done with training, there are certain requirements. So we really wanted to get educated, and there is a ton of education out there. So there's a lot of research that's available about refugee mental health care. And like I said, that may not have been as common 20 years ago, but now that's really, there's a robust base of literature and then trainings also. So there are conferences that you can go to just on this topic, or a conference like I was just at the American Academy of Child and Adolescent Psychiatry, and there was a session on migrant mental health. So in our journal, just what I got this week, there are articles on that. So it's something that psychiatrists understand. We are very needed in this space, and so we are getting educated so that we can give excellent care that's targeted for that person. We want to meet patients or people where they're at, and so first of all, we just really need to know where they are at.
Well, that's really interesting. I'm glad that there's literature and good resources on this, although it's sad that that is needed, and that we are in this crisis. I wanted to turn to schools for a moment, because for many migrant kids who are, going to be assimilating, they're going to be attending maybe a public school. And for a lot of them, I feel like it's going to be the most feasible place to address a lot of their needs is within the school, maybe a school counselor. So how is Talkiatry thinking about setting up a presence there or collaborating with school counselors to treat some of these kids?
So as a child psychiatrist, I almost always collaborate with the school counselor. It's absolutely necessary, because that's where they spend most of their time. And I think that you're really right on point of how can we do that better. I think if you remember COVID, everybody remembers COVID, children weren't in school, and that is truly where they get a lot of their services. So children with autism get a lot of services at school. They have paraprofessionals that pull them out of class and teach them skills. So they really lacked that whole time during COVID. So that made it very salient to us all how important schools are. There aren't a lot of organizations that are going into schools yet. I mean, it's if you can imagine, it's a complicated arrangement, and it's something that I, as a child psychiatrist, feel very strongly about, that we do need to start reaching into schools. Just if you're thinking of non-migrant youth, how great would it be for a kid to not have to leave school, go to an appointment, and then have to come back? So they miss, 3 classes, and their parents have to leave work. And if you don't have a lot of resource, that's a huge burden. So even for kids who aren't migrant youth, that's a huge burden. How great would it be to be able to go into their schools virtually, have both their parent and their child, and maybe even the school nurse at times on the screen, or the school counselor, and all make a plan together? We're not quite there yet, but it's a passion of most child psychiatrists, or many of us it is. And so I think that this migrant youth really just kind of is even it's even more necessary. So that is something that we'd like to do, but we're not there yet, but it is a goal.
Yeah, that's great. Yeah, that would be so much more productive. And as we were talking and describing this process, I was thinking how necessary is it for these migrant youth to have somebody there, or helping them out, getting connected? Because, I would imagine for some of them, maybe they're not too familiar with technology, or maybe they don't have a phone. So how do they get connected? And is there somebody there kind of helping them, looking over their shoulder, making sure that they're set up correctly?
Yeah, exactly. They're not going to necessarily have a phone. And so it's easy in the shelters, because they will have a computer there. They will sit down, somebody will get them connected. And that's the training that we're doing right now, so that goes really smoothly. Training the shelter staff on how to get connected, what types of things we need, what forms we need filled out, what consent we need. And so when they're in a shelter, that's really kind of slick and smooth, and we can make that easy. I think it's going to be harder once they leave the shelter, and it's what we bump into even just with a regular family, or an American family. Do you have the right technology? Is your Wi-Fi strong enough? Are you on a phone, or are you on a computer? It's often easier to be on a computer. So you're right. I think those are some of the challenges that we will have as they leave the shelters. But in the shelters, it's really nice and kind of contained, and they'll have the technology that we need.
Yeah. Is it typically you're anticipating these to be video calls, or is there a case where audio might be more appropriate?
We want, 99.9% of our visits to be on video, because if you think about it, it's already different to have a doctor in a different place and not to be sitting face to face with them. I think that it's really important for them to see us, to build trust, them to see that we have an empathetic stance, that we are listening, that we care, that we're not judging them. And then it's really important for us to see them. I want to be able to see when they start to shut down, when they start to cry, or when they start to get angry or get irritated and edgy and want to leave. Those are all things that are important for me as I try to understand what type of illness they have, what type of symptoms they're struggling with. They might not be able to say, I feel sad, but they get really shut down and they look at the floor and they don't look at me anymore. And then I kind of know that that's probably the emotion that they're starting to have. But they just don't know how to say it.
Yeah, so that's interesting. So like body language is still important to see and to preserve in a digital setting.
Yeah.
Are there any effective known methods for treating PTSD, specifically among migrant youth, that you can talk about? Something that you and your providers are planning to employ to help with PTSD symptoms?
Yeah, so there is something called cognitive behavioral therapy for trauma. And so that's a very, it's fully researched. There's a lot of literature that indicates that it's a very good treatment. And while me as a psychiatrist, I may not be doing the hour-long sessions of that CBT, trauma-informed CBT, I still need to know how it works and how to support what the therapists are doing in their therapeutic work with the patient. And we call that supportive therapy. So I'm there to help them reframe their experiences. Their therapist is doing that also in these hour-long sessions, but I'm there to support that treatment and to also provide my own supportive therapy for that patient. So I might not be doing the full trauma-informed cognitive behavioral therapy. I should use the actual words. I might not be doing that, but I can definitely support what they are learning.
Interesting. Yeah, that's great. And you have this contract with HHS to serve this population. Can you talk about why you think that they chose you as a provider? Maybe some of the things that you presented as evidence of your capabilities and your expertise in serving this population. I know you said Talkiatry hasn't really served migrant youth before, but clearly there was something compelling HHS saw in Talkiatry. So maybe you can give a few pointers on what you think made that compelling case for them.
Sure. We are probably we are one of the largest national organizations of psychiatrists. So all of our clinicians are board certified or board eligible psychiatrists, and including our child psychiatrists. So I think that that's very attractive because that's just hard to find. And it's especially attractive when you think about the fact that we're in 43 states. So our doctors have licenses in 43 states, so we can practice in those states. So I think that was very attractive to them. The fact that we do telepsychiatry, so we're not limited by having to come and physically be there. I think that's attractive. And then, one of the things, we have very good outcomes. We do track our outcomes of our patients through standardized scales like we call it the GAD-7 or the PHQ-9. So we have good outcomes, and we do show those to organizations who want to contract with us. The other thing that part of our ethos is that we do spend time with patients. We don't do 15-minute we call them med checks or medication checks. Our minimum visit is 30 minutes. And our evaluations for children are 75 minutes and 60 minutes for adults. That's more than the industry standard, but we feel very strongly that to really understand the whole person and to also give that supportive therapy, that we know is important to have a good clinical outcome, we need to take time with people. And so that is something that we talk a lot about with any partnership. Any partner that we're considering partnering with is kind of our model of care. And part of that is really that time that we take with patient, that supportive therapy. And that also helps us really understand the biopsychosocial issues that are happening. I can't do that in 15 minutes, but I can do that in 75 minutes for an evaluation, and then in 45 or 30-minute follow-ups. I can do that as a psychiatrist.
So I'm glad that you brought up, the length of these sessions, because something I was wondering about is how long do migrant children need to stay in treatment? Is it the same as other kids in the U.S., or what's the average time that you're anticipating they'll need to be seen?
I don't know that we have a specific average time. I mean, it just depends on each person. So they may have a lot of predisposition already to mental health problems. So we have to deal with that biological part. And then they also have all these social barriers and impacts. And so when you continue to work with that burden of social impacts plus biological predisposition, I think that's that's going to take a longer time to treat. So I do anticipate that that these children and soon to be adults, some of them will be in treatment for longer periods of time. But like I said, resilience is still, they still have resilience and they have a lot of strengths. And one of the things we also want to do is focus not just on the things that are going wrong, but really what do they bring to the table that are a strength of theirs? How can we improve that? How can we focus on that and build them up in that area so that they become resilient and so that they do recover more fully?
Yeah, that makes sense. And I was wondering, to what extent does Talkiatry treat immigrant children that are in the U.S. and living in the U.S. and are not necessarily refugees? Are there any similarities between the two populations that you can take some of the lessons learned from those kids and apply them to this population, or are they kind of totally separate?
No, I think that they're really they're very similar, and it's just how far down that path are you? Did you immigrate here 10 years ago? That's very different. And you did it at 10 years old. That's very different than if you did it at 5, or maybe if you did it at 25, so there are differences there, but I think that they do still struggle with some of the same things: language barrier, cultural differences, maybe being at a different place educationally. Maybe they weren't in education for years, and so now they're having to be in an American school with our expectations. So I do think that they face some of the same struggles, and we can use, like you said, those lessons learned of treating people who are new but are settled.
Mm-hmm. Okay, yeah, that makes sense. We talked about cultural barriers earlier, and language barriers specifically. I know we hit on translation a little bit, but can you walk us through how translation services integrate into the Talkiatry platform and how many languages you're able to offer, how that works in real time, or maybe not in real time?
Well, we do need it really in real time. I mean, you're right on point with that. In the shelters, they'll often have Spanish-speaking staff that can help us. We have a lot of, since we have so many psychiatrists across the country, we have a very diverse psychiatry group. And so that will help too, because a lot of our psychiatrists are bilingual or multilingual. So there will be that that will be a benefit. But that's one of the things that we're also doing right now is signing contracts, bolstering that, having a robust translation service. And what they can do is they can just be in the session just like they are. If I'm in a session face to face with somebody who doesn't speak English, I would have a translator right there, and I would talk to the patient and the translator would translate that. So we'll do the same thing. You still talk directly to the patient because that's your patient, and then just somebody else is translating that. It's not easy, takes a little bit longer, but it's certainly effective.
Yeah, that's an interesting model. But I would imagine, yeah, that you still have to use your own voice and your own intonation and emotion when communicating.
Exactly. And that's why you don't really ever want to talk to the translator. You want to talk right to that person. You want them to know exactly how you feel. They can see, like you said, they can see my expression. They can hear how I'm saying it. I might say it softer. Oh, that sounds really hard. Tell me more about that. So I think that's important.
Yeah. And you said that the HHS is the one that is providing the social services and offering that additional support. Can you talk about how you're planning to coordinate with the agency to make sure that referrals are, close the loop on, that that a patient that needed that service got it and is actually seeing the benefit, or maybe, you're seeing that reflected in the treatment path?
Yeah, I think that's great. That close the loop is really important. Before we started to even work on this, it was important to me that they had clinical staff there. They don't have psychiatrists, but they do have mental health licensed staff members, and usually it's social workers. And so I needed to know that they would be able to review the chart and understand what I'm suggesting and get them the right treatment. And so we will be collaborating very closely with those clinical staff members to close that loop, make sure that when I say they need this type of therapy, that's happened.
Great. That's great. Is there anything else that you wanted to talk about that I haven't asked about yet?
I think that, the part about prevention, I think, is really, really important for migrant youth, but also for anybody. So we learned that in 9/11, one of our psychiatrists was very involved in prevention work after 9/11. And there's a lot of research now that proves that that's helpful. And that's why we want to get into this so quickly with them. We don't want to wait until they're 18 or 25 and have been managing this burden of mental health symptoms for 15 years. We want to get to them when they're young, and so that we can change the trajectory of their life, and so that they can be engaged in school, they can be engaged in things they love, they can make friends, they can they're not feeling so anxious or depressed. And you had asked, I think, what we see most often, and it's usually just like it is with American population. It's anxiety, depression, and post-traumatic stress disorder. And so getting in there early is just so exciting for us. That's why I became a child psychiatrist, is to see if I could change the trajectory of people's lives. And so that's what we want.
That's wonderful. Yeah, I think, as with so many things related to health, early intervention really is paramount.
Exactly. Yeah.
Well, thank you so much. Thank you, Allison, and thank you all to our viewers who joined for this panel. I learned so much from this conversation, and I know that this is something that we're going to be talking about for a long time to come as the U.S. continues to see migrant youth coming into the country. So thank you all so much, and I'll just say thank you all so much.